we're a couple minutes late. We are taking up H206 this morning, which is usually we call it a technical bill to DEVA.
Housekeeping, we call it
Housekeeping bill to DEVA. And we have Jen Carvey from Legislative Council who's going to walk us through the bill. So you can find it on our committee page if you want to follow along. And then we'll have Ginger Iris here with DEVA and Stephanie Winters, who will provide some testimony on it. Jen, I'm going to kick it over to you.
Okay, good morning. Jennifer Carvey, Legislative Council. I'm actually just joining the Zoom and so I can put it up on the screen.
And let me just, so on our committee page, it's actually under Amren's name.
Yeah, okay.
So everyone.
I thought we were doing something totally different.
Draft the bill.
Yep.
And I am covering it for her today. Sorry, that's my standard Zoom computer unmuting itself. And just a second, I think it's trying to put up what I want. There we go. Okay, should be in business. So this is H206, an act relating to miscellaneous changes affecting the duties of the Department of Vermont Health Access. As the chair said, this is what we often refer to as a housekeeping bill. I like to make the distinction between housekeeping, which is some cleanup stuff that maybe an agency or department wants, and something that is truly technical, which is usually when my office is asking you to fix something statutes. There's a good summary of the bill, but we'll jump into the language. The first section deals with a topic this committee has been talking about a lot recently, which is Medicaid coverage for adult dental services. And under existing law, as added a couple of years ago, Vermont Medicaid has to provide coverage for medically necessary dental services provided by a dentist, dental therapist, or dental hygienist working within the scope of their license. And it requires coverage of preventive services and diagnostic, restorative, and endodontic procedures. And those procedures are capped at a maximum of $1,000 per calendar year. I think in your budget letter, you are talking about the proposal from the department to increase that to $1,500, and then you wanted them to look at also what it would look like to get rid of the cap entirely. This is doing something a little different with the existing law. So this is saying that in the existing provisions, DEVA can approve expenditures in excess of the cap when exceptional medical circumstances so require. And the bill would add language saying that exceptional medical circumstances include emergency dental services. And it also says that certain individuals will not be subject to that annual cap. And those are individuals served on the Community Rehabilitation and Treatment, CRT, and Developmental Disability Services waivers authorized under Vermont's Section 1115 demonstration waiver. So that's the global commitment, kind of larger waiver.
Nice question.
And better just get through this section.
Medicaid beneficiaries who are pregnant or in the postpartum eligibility period as defined by the department by rule.
So Leslie, is the question language or policy?
Language.
Okay.
I just wanted to make sure I understood that the exceptional medical circumstances include emergency dental services, and I wasn't sure if that it applies to everybody or only the following individuals, and that confused me.
Yep. So I believe it is everyone. I will look at Ginger. I think the language may need to be broken out a little bit more, but the emergency medical services cap is doesn't apply to anyone, and then it also says because that list of people are people to whom the cap doesn't apply at all. So it would not make sense to have those people only not subject to the cap. To have those people not subject to the cap and then say they're not subject to the cap for emergency services, which is a backward way of saying, I think it applies to everyone, but I think it would probably be a good idea to break those two.
Good, thank you, because I was struggling with that.
Into an A and a B. I have also suggested to Ginger that it might be helpful to have a definition of emergency dental services.
That would be, yes.
In here. So we'll make some notes.
Art,
I think they do have a definition. We'll just.
that we could put in.
Yeah.
My question's more policy if it wants to wait.
Yep, that's right.
Yeah.
Built in.
Yep.
All right. So that's the end of the dental section. I will move on to section 2 if everyone is ready. Section 2 deals with some information around Medicaid and when there is another payer involved in addition to Medicaid. So one of the provisions under existing law requires insurers. So if there's an insurer in the picture as well as Medicaid, it requires the insurer to accept certain things from the Agency of Human Services with respect to Medicaid recipients. And then the new language says, if the insurer requires prior authorization for an item or a service, this would require the insurer to accept AHS's authorization that the item or service is covered under the Medicaid state plan or waiver, as if that authorization were the insurer's prior authorization. So this is a little bit like it makes me think of our deemed licensure. So in this case, it would be sort of deemed prior authorization. They would be, the insurer would have to take the AHS's authorization that the item or service is a covered service for Medicaid purposes, as though that were satisfying the insurer's prior authorization requirement for that same item or service.
So can I maybe repeat that to make sure I understand it?
Sure. I'll make sure I'm getting it right. Yes. Okay.
So let's say there's someone with Medicaid could have another commercial insurer as well. That's like, I think where I'm lost. Yes. Okay. So let's say there's a commercial insurance and Medicaid. I go in for a service that Medicaid would provide a prior auth for. The commercial insurance will also have to accept that prior auth. No.
I think it's less that it would be a prior authorization, that AHS has a prior authorization, which is that it's a covered service. It's something that Medicaid covers. If it's something that Medicaid covers, then it would have to be accepted as satisfying the prior authorization requirement for the payer.
Okay.
Sure.
So a service that Medicaid covers without requiring prior authorization?
The language here says that the item or service is covered under the state plan or waiver. It is silent as to whether prior authorization is required under Medicaid for that particular service or item or service.
I'm just thinking about what if both the commercial payer and Medicaid require prior authorization on that service? Do you then get prior authorization from Medicaid, and the prior authorization from Medicaid must be honored by the commercial payer?
I think that's part of it, but also even if prior authorization is not required under Medicaid, if it was covered by Medicaid, if it's a covered service for Medicaid, then the insurer accepts that as satisfying the prior authorization requirement.
So let's
Okay,
hold that
let's
and
hold
come
that
back
for
when we have
two.
policy. Yeah.
Yeah, that's unclear.
Okay, and then the next piece of that section deals with, again, with the interplay with Medicaid and private insurance. And in this provision, it specifies that an insurer shall not, and under the existing law, there's language around an insurer not denying a claim submitted by AHS based on things about the claim, when it was submitted, the form it was in, things like that. And it also now would require that insurer or prohibit an insurer from denying a claim submitted by AHS on the basis of failing to obtain a prior authorization for the item or service for which the claim is being submitted, if the agency has transmitted authorization that that item or service is covered by the Medicaid state plan or waiver under that provision we just looked at. So this is not so it's kind of the other half of what we were looking at. The insurer cannot require or has to accept Medicaid coverage as satisfying the prior authorization requirement, and the insurer under this provision cannot deny the claim as failing to meet prior authorization if that information from AHS about it being a covered service was sent to the insurer. So these two provisions go together. All right, and then we get to section 3. This deals with the Vermont prescription monitoring system. A lot of this policy is handled down the hall in the Human Services Committee, but Vermont has a prescription monitoring system that is in large part to look at prescription and use and misuse of opioids and other controlled substances. Pharmacists are required to report prescription information to the prescription monitoring system. Providers are required to check the prescription monitoring system before prescribing controlled substances to anyone to see where else they may have been getting prescribed the same or similar medications, what else they would be on that would fall under those categories. As you might imagine, this information in the prescription monitoring system is heavily regulated as far as its privacy. And so there are provisions in the law about a limited list of individuals who have access to query the Vermont prescription monitoring system. So that's to actually go into it and look up information. And then there's a separate set of specific individuals who are allowed to get a report of information from the prescription monitoring system from the Department of Health. So right now we're in the query side. And under existing law, the Department of Health can only provide query access to this list of people. So healthcare providers, dispensers, and delegates, people who work on the VPMS. And then in existing law, we have the medical director of DVA and the Medicaid director of DVA under existing law for the purposes of Medicaid quality assurance, utilization, and federal monitoring requirements with respect to Medicaid recipients for whom a Medicaid claim for Schedule 2, 3, or 4 controlled substance has been submitted. So right now it's just the medical director at DVA. This language would add the pharmacy director of DVA and also a designee for each. I think you're going to hear a modified version of that proposal from Ginger when she comes up after her work with some of the stakeholders that would be scaling that back.
Art?
But that's what that language says.
Could you move that up where you just had it, Jen? Yeah. It just is a technical thing. Do we always have to say the designee of the director, or wouldn't that be assumed?
That's a great question. It really depends in this case because access is so carefully protected. It really is, in some cases, you'll even see in the rest of the statute, it will say things like the commissioner of public safety personally. It's really focused on, yes, on really limiting access to who's looking around in your medical records, your prescription records. But yes, you're right. Typically, we will have the secretary or the commissioner doing a report, and it's probably not actually that individual who's writing the report.
Okay.
Although it may be submitted under.
But by designating this, you're making it very specific as who can do it.
Exactly,
Gotcha.
exactly.
Thank you.
So yes, as a general matter, no, we do not say designee everywhere. Although often when we're creating a study committee or something like that, we will put on it somebody like the medical director or designee.
Gotcha.
To be clear, they can send someone else.
Yeah.
All right, and then I believe that is it. It would just take effect on July 1st.
Okay. This is just a language question. Back to section 2. 2, it says, if the insurer requires prior authorization for an item or service, is something missing? They must accept?
You have to look at the lead-in language. So the lead-in language in D is on and after July 1st, 2016, an insurer shall, and then it says, if the insurer requires prior authorization, accept. So it's really the insurer shall accept.
Got it. Thank you.
Great. Let's have Ginger come up with DVA and we can talk about policy. Thanks, Jen.
Good morning.
Good morning.
Morning.
Good to see you.
Thank you. Ginger Irish, Director of Communications and Legislative Affairs at the Department of Vermont Health Access, and happy to answer any questions that you have, if that's helpful, or walk through whatever you prefer.
That would be helpful. Thank you. So I think we just want to make sure we understand the first 2 sections. So around the prior auth. So if you can just talk about it policy-wise and how you see it.
Absolutely. So there was a federal change in 2022 as part of the Consolidated Appropriations Act. Basically, what it's saying is that if a patient receives a service through Medicaid and Medicaid doesn't know that they have another insurance plan, which could be commercial or Medicare, Medicaid is always the payer of last resort. That's because it used states.
Does everyone understand what that means? Payer of last resort. Okay.
Yeah, always bill Medicaid last, but sometimes Medicaid doesn't know somebody has a primary. So basically what this law does is it says that if Medicaid was asked to provide a service, approve the service, and paid for the service, and then later learns that that patient had a primary insurance plan, that primary plan can't say, well, we would have required a prior auth, so we're going to deny paying Medicaid back. This means they have to pay Medicaid back if Medicaid reviewed and approved under their plan, their state plan, that the service is covered.
That makes sense. Does that work for you or no?
Pro in this is,
I totally understand the, that you'll be reimbursed by payers when you didn't know. But I'm just thinking about this, even when you do know, if this is now in statute, this isn't just requiring claims that you would send to a payer. It would mean everybody. So if a patient has Blue Cross Blue Shield and Medicaid secondary, then if Medicaid doesn't require a prior authorization on a service, but Blue Cross Blue Shield does, then Blue Cross Blue Shield would have to pay it because the payer of last resort, Medicaid, doesn't require an authorization. Or if both Medicaid and Blue Cross require a prior authorization, isn't this basically saying get Medicaid's prior auth, and Medicaid's prior auth must then work for Blue Cross? And I'm not talking about look back. I'm talking about like real time where you know that there are two payers.
So real time, when you know there are two payers, Medicaid isn't billed first. So this only applies if real time you only know about Medicaid and you bill Medicaid and later learn that there's a different primary.
Okay.
When you learn that, this is protecting Medicaid, saying Medicaid had no way of knowing if Blue Cross or Medicare required a prior auth, had no way of collecting a prior auth. If Medicaid covers it, but primary, which should have been billed, primary has to reimburse Medicaid to get those funds back because they're the payer of last resort.
Where in the preceding language does it just talk about Medicaid claims only? Like your claim to a payer that you found out later on was supposed to be primary? Because, I'm just reading this as.
Right, you don't have the whole statute in front of you.
Okay, that's it.
Remember.
So this is all about Medicaid claims
We are, yes, we are in Title 33 in Chapter 19, which is all about Medicaid.
Okay,
This is a series of sections in 1908 and 1909 and others around there about the section on subrogation. That's all about the interplay between Medicaid and another insurance. And it specifies.
I was missing context.
Okay, yep, and it specifies in 1908 that Medicaid is the payer of last resort to any insurer that contracts to pay healthcare costs. So I think that's where Ginger's example comes from.
Yeah, great.
Thank you. Great question. Yeah.
And this change is due to a federal law.
Yes.
Okay, go ahead, Art.
yeah, on page 2 of the bill, and my only question was, item B, the Medicaid beneficiaries who are pregnant or in postpartum eligibility period. I'm wondering why that's in there. What specific thing, and it's probably very legit, I'm sure it is, but I just want to understand why they wouldn't have the cap.
So this is for the dental piece?
Yes.
So in 2012, I believe in the big bill.
It would be the budget bill.
Passed, yeah, the budget bill, language was passed to remove the cap for women who are pregnant or in the postpartum period. But that language just never made it into state statute, which we discovered when we were looking through this language to add the two services we discussed earlier this week, and that we can talk about more, the emergency coverage, and also for the two developmental disabilities and community mental health and rehabilitation groups. So that's just a technical change, really, to say.
Okay.
Probably should have
So
been
that's just
introduced a
been
while
there for a
back.
long time.
And that's been our
I
practice.
just,
Yeah.
I don't quite understand it, but that's fine.
I have a question on and I don't know if this is for Ginger or Jen. So if the dental appropriation we just put as a priority in our budget, if that goes through into the budget bill, which part of that is increasing the cap to 1,500, will that then make sure that this language, this underlying language where it's capped at 1,000 changes to 1,500?
Yeah, I
Like that's
forgot that this was in the statute, so we may want to put, if you are interested in do you have something?
I do, if that's okay, like
Yeah.
to speak on behalf of the department. Because the appropriation to increase rates is in the big bill, I think our preference is to, if there were to be a change, to increase the cap, to put it there too.
Right, that was gonna be my point. is
Okay, thank you.
I would not, I didn't realize it was in statute. If
Okay.
you are interested in accepting that proposal to increase the cap to 1,500.
Yes.
That should go in as language in your budget.
Okay, so I put it, so when I sent, you're saying I put it in the notes section,
Okay.
so put it wherever you, or highlight it however you need to
Okay,
highlight
great,
that.
yes, I will flag it and then I will draft the language to just make that.
Okay, great.
So if I may, so to understand this process, then this $1,000 is in play because of what's going into the budget, right? So should this bill wait until we get through that process, or does that get housekeeping, whatever that word might be, next time?
Yeah, great question. That is what we would consider in our statutory revision process, where we, over the summer, as through legal staff, we work with the publisher to take all the acts that were passed and incorporate all of the changes that were made into the statutes. We would look at those two things, two acts that amend the same section but do it in ways that are not in conflict. We would incorporate both sets of changes in the expectation that the intent of the understanding that the intent of the legislature was not that the later enacted one wiped out the changes from the earlier enacted one during the same session. So you don't have to keep track, we don't have to keep track of all the 20 bills that might be amending this section of law and try to make them all work as they move through the process, as long as they're not in conflict. So if this committee changed this $1,000 cap to a $5,000 cap and the Appropriations Act changed it to a $1,500 cap, that would be a conflict. We would have some trouble. We try to avoid those. But something like this where you'd be changing the number in one place and then adding some exceptions in another place, you're presumed to have kind of had all of that in mind while you were working on it, and we would carry all of those changes into the green books.
Okay, so just to make sure I understand that, what in the short way, we'll pass this as it is, you'll reconcile it over the summer, and what's in statute will say 1,500 should that pass.
Exactly.
Okay, thank you.
I want to just talk about the cap a little bit because I was talking to Leslie yesterday and I might have confused a situation. So can you explain the cap again?
Yeah, happy to.
Yeah.
So essentially, there is a cap on how much Medicaid will pay for dental services. It applies to some groups of people, some populations, and not others. So groups excluded from the cap include children through the age of 20, and that's part of how Medicaid works, that we cover every service for children essentially. Women in the postpartum period or who are pregnant. Currently, postpartum means 60 days after giving birth. Starting April 1st, Vermont Medicaid is extending that to 1 year. So that's a longer period that dental will be covered for those women. So basically how the cap works is preventive services are not counted toward the cap. That includes 2 cleanings per year. There can be approval for additional preventive services. So that cap of you can only spend $1,000 on dental, none of those preventive services go toward that cap.
It's not a deductible, it's.
Right, so I have Medicaid and I need service outside of 2 cleanings. I pay up to $1,000.
No, Medicaid pays up to
$1,000, okay.
It's kind of like the reverse. I think.
Yeah, reverse, that's where I got confused, okay.
Yeah, like typically medical insurance, you pay out of pocket to an amount, then they pay.
just the opposite.
This says we're paying everything up to a point, then you pay if you need more, or there's a room for Medicaid to approve.
And then how does emergency services play into that? Once the $1,000. So
Yeah.
I'm on Medicaid, I've had all this dental work up to $1,000, but now I need a root canal.
Yes, so emergency services are pain, infection, or bleeding. That's what it's treating. If you hit that $1,000 and you need emergency services, Medicaid can pay for those. That's one of the changes that we're proposing, is to cover those. And that, again, applies to that group of people 21 plus. So not the groups who don't have a cap. None of this changes how they receive services because the cap doesn't apply to them.
So that's why that language needs to get separated, because they're different populations, right?
I think it's just a bit confusing the way it's currently in here, so I would break it out as a kind of the after exceptional medical circumstances include emergency dental services, then break out that would all be in a subsection A, and then B, the following individuals are not subject to the cap.
So can you give me an example of what a non-emergency service would be that's not preventative?
That is a good question. There is a list that I would be happy to provide.
That'd be helpful. In case someone asks on the floor.
Yeah, just
Like fillings, cap.
thinking through,
That's exactly, but if you had pain,
Right, so yeah,
now is it covered? And that-
right, like so a root canal usually has a lot of pain
Oh, yeah.
to it, is that, so if you can send the list,
yeah,
that'd be great,
definitely.
thanks.
Yeah.
Okay. And then were there any other changes that you were recommending to make, or have we covered what?
We've covered that in terms of the dental here.
Okay,
I think there was a question on Tuesday about why those 2 specific populations, and I'd be happy to share more information about that if that's helpful. Sure. So we were able to negotiate those 2 populations. This is folks served by developmental disabilities program and community mental health and treatment programs through the global commitment waiver. So that basically means we got permission from the federal government to waive the cap for them. Also, there are funds we are moving from DMH and Dale that were already used for dental, moving over to DIVA so that we can draw down federal match. And those were the populations, my understanding is those are the populations served by those funds. So it sort of aligns with continuing to serve those same populations.
Okay.
Yeah, and I think you had asked Representative Rebecca about why not everybody in HCBS, I think was your question. Yeah. Yeah,
What was the
you're
answer?
welcome.
the federal government allowed for these 2 populations,
It says it's only that.
right?
Into the waiver.
All right, any other questions on the dental piece? Leslie, are you good?
For now, yeah.
Leslie, it's sponsored this bill, so she'll be reporting this bill. So we'll make sure she has what she needs. Okay, and then the part about the Vermont prescription VPMS.
Yes.
I think there might have been you were going to change something here. So you want to talk about that?
Yeah, so we heard from the Vermont Medical Society, who we work with, and they expressed that they would be more comfortable if we just had the medical director or a designee having access, not also the pharmacy director and a designee. While it's our preference to have access for both of those key roles, we're okay with that suggestion change. So I let Jen know and wanted to let the committee know. I believe Stephanie.
She's on the line, so we'll hear from her in a minute.
Yeah.
Did they say why?
Well, she's going to be on the line, so we can ask her in a minute. She's on Zoom.
Oh, okay.
So we'll have her come in a minute. She probably listens, but so let's just hold off until it's her time. And I was going to ask a question. I forget what it is. All right. So you would be okay with changing that?
Yeah, and I'd like to just offer that the reason we're really asking for the designee is because if the medical director isn't available or the position is vacant, there's no way for DIVA to access to protect patient safety for these controlled substances and opiates. So we're really wanting to be able to assure that at least one member of our staff has access to that system.
Yeah, that makes sense to me. Good.
If the position's vacant, how do they designate somebody?
So we would be able to do that if before that happened.
If the medical director position is vacant, you mean?
Yeah.
Yes.
Yeah, you're fine.
And the designee of each director. So does the person that the director designated still have the designation even if the medical director is no longer the medical director?
Gets designated before they leave.
Okay.
The commissioner usually designates them, I think.
Any other questions for Ginger?
I have one, but I'll take it offline before you go. I don't want
Yeah.
to waste.
Great.
Whatever your preference, thank you.
Yeah, I'll just ask you before you go out.
Great. Stephanie, are you there? There she is. Good morning.
Good morning. Thank you for having me this morning. It was the most beautiful snowfall here in Williamstown that I think I've seen in a very long time. The snowflakes were so huge. So now it's stopped, but happy winter day.
Exactly.
Finally getting winter in March.
Yeah.
For the record, Stephanie Winters. I am the Deputy Executive Director of the Vermont Medical Society. As you may know, I also wear a number of other hats, but I'm here today on behalf of the Medical Society. And first off, I want to just thank the committee for what I would call a marathon couple of weeks on some really important priority legislation and budget priorities, and your work and thoughtful discussion is just really appreciated. So thank you for that.
Thank you.
Today, I will be speaking only to Section 3 of this bill regarding access to the Vermont Prescription Monitoring System, or the VPMS. Just because this is your first time discussing the VPMS this session, VMS wanted to share our perspective on the use of the data in this important registry. And I know Representative Cordes had some questions, and hopefully they get answered in our testimony as to why we're really just worried about limiting the access. VPMS is an important tool for clinicians to use for improving clinical care and safety. And VMS was involved in the design of the VPMS at its inception, and has always been really clear that the focus should be clinical improvement and coordination and not enforcement purposes. As you know, or can probably ascertain, this contains extremely sensitive healthcare data, each patient and clinician's prescription history. So any access beyond prescribers and patients should be very limited. All other agencies discussed in the statute regarding access to VPMS data have only one identified role and a designee. For example, the Commissioner of Health or the Commissioner's designee, the Commissioner of Public Safety personally, or the Deputy Commissioner of Public Safety personally. So we had initial concerns with the one new position and two designees being added in the bill as introduced, but Jessa Barnard, our executive director, was able to speak with DIVA yesterday and understand that they are open to only adding a designee for their medical director, and we would be comfortable with this approach. So I think really just outlining that limited access to this really sensitive information is preferable, and we would be comfortable with adding a designee. So thank you.
That helps. Okay. Any other questions for Stephanie? No? Great. Thank you, Stephanie, very much.
Yeah, thank you.
Have a great day. Enjoy the snow.
Thanks.
Right. So this will be the extent of our testimony on this bill, unless anyone has concerns or questions at this point.
My concern is, I'm not sure I completely understand this prior auth thing.
Ginger, can you come back up?
Well, I guess I need bullets, like 1, 2, 3, 4, when this happens and this happens, as just something very clear on the process.
Yeah.
And I'm a little stuck there, but I don't need to take people's time for that here.
Okay.
Because I'm very happy to work.
Okay.
with you.
Okay.
But just so you.
I'll just add that we said something with the steps of how this would happen, like Medicaid bill is billed for a service. We learn later that there's a primary or insurance, and then we need to collect. So
Okay.
I think that's helpful. I'm happy to share it with the full committee.
Okay, yeah, that'd be great if you want us to share it with the
Yeah.
committee, if you can just send it to
Yeah.
Claire. And then Leslie, you can work offline with Ginger.
Yeah.
Totally.
Happy to.
Yeah.
It's complicated.
Okay,
And,
yeah. Which is
billing.
helpful, just to be able to discuss it, so. So we have the healthcare advocate here. Would you like to comment on H26 or are you just coming to visit?
I think I'd like a minute to, I have been listening.
Okay. Okay.
But I think I do have a question or two. I think it makes sense to ask Diva first.
Okay, why don't we take, let's go out there and take a 10-minute break and we'll determine if we need